So, hello, this will be hypertension part 2. So, here now we will study causes for hypertension. So, the first cause for hypertension is it is an essential hypertension. So, it is idiopathic in nature, so there is no known cause for it, and it is the most common type of hypertension, and it has a prevalence rate of 85 to 90%. Then the next one is secondary hypertension, which can be caused due to a renal parenchymal disease, due to renal diseases. And the most common congenital cause for secondary hypertension is coarctation of aorta. So renal disease is like uh, it's not a congenital cause, but the most common congenital cause is coarctation of aorta. uh, and like how will you know if coarctation of aorta is causing the hypertension? The differential finding you'll see will be there will be cyanosis in the toes of the patient. So the fingers of the patient in the upper limb or on the hand will be pink, but the toes in the lower limbs, they will have cyanosis in them, and that will be the differential feature which will let us know that okay, it is due to coarctation of aorta. So here there's just a formula: cardiac output into pulse rate is blood pressure. I think this is pretty basic and everyone knows that. So in coarctation of aorta, what will happen is the blood pressure in the upper limb will be elevated, but the blood pressure in the lower limbs will be decreased. And normally the blood pressure in the upper limbs is one is lesser than 120 by 80, and in the lower limbs the blood pressure a little bit higher, which is less than 140 by 80. There is a 20 millimeters of mercury or less difference between the systolic blood pressure of upper limbs and lower limbs. The diastolic blood pressure does not change due to the aortic recoil or the peripheral resistance in our limbs. So in coarctation of aorta, there are many varieties. There is also a preductal coarctation of aorta. Uh, so preductal coarctation of aorta, and there's also postductal coarctation of aorta. So in preductal and postductal, the difference is where is the coarctation, or like where is the narrowing. uh, what are the causes for unequal blood pressure in the left and the right arm? So the first cause we'll study is Takayasu arthritis, which is a chronic disease, and there's a narrowing of the ostia or the ostium of the artery of the left subclavian artery. And then there is preductal variety of coarctation of aorta, which is also a chronic disease. Then there's supraclavicular aortic stenosis, which is also a chronic disease. And there's a Conda effect. And supraclavicular aortic stenosis is associated with Williams syndrome, and there's aortic dissection, which is an acute disease, and it is acute in nature and not chronic. And there's an antegrade progression in aortic dissection. uh, s- supra Supravalvular aortic stenosis can be seen due to vitamin D toxicity. So, what are the secondary causes of hypertension? So, I just wrote renal parenchymal disease. So, in renal parenchymal disease, there is chronic kidney disease and chronic glomerulus nephropathy (CGN). There is renal vascular hypertension. Uh, it, for this, I'll give you an example. In a 20-year-old female, it can be due to FMD. In a 60-year-old male smoker, it can be due to atherosclerosis, or there can be Takayasu arteritis. There can be metabolic syndrome which can be the secondary cause of hypertension, or like syndrome X. Metabolic syndrome is, I think, really it has central obesity, which is really common in Indian population. There is impaired glucose tolerance, so the fasting blood sugar will be high. There is hypertension, and the triglycerides to HDL ratio will be changed. So there will be high triglycerides and low HDL. In and so diag- how to diagnose central obesity in males? The abdominal circumference, if the abdominal circumference is more than 90 centimeters, then it is central obesity, and in females, if it is more than 80 centimeters, it is central obesity. And if the three or more of these features are present out of the five features, the person has metabolic syndrome. And metabolic syndrome is the secondary cause of hypertension. And obstructive sleep apnea, or OSA, is also a secondary cause of hypertension. uh, then there's also endocrine causes like OCP use, hypothyroidism, thyrotoxicosis, bilateral adrenal hyperplasia, or Conn syndrome, in which the aldosterone renin ratio increases, and there's acromegaly, in which the growth hormone increases. So in hypothyroidism, there is isolated diastolic hypertension, and the heart rate will be low, but still the patient will be hypertensive in hypothyroidism, and it is only isolated diastolic hypertension. So the systolic will not increase, but the diastolic will increase. In thyrotoxicosis, the symptom will be the heart rate will be increased, like really increased. In bilateral adrenal hyperplasia, BH or Conn syndrome, there will be aldosterone renin ratio will be increased, and then acromegaly will cause the increase of growth hormone. There can be isolated systolic hypertension. So in old age, as compliance of the arteries decrease due to the calcification of the arteries. In hypothyroidism, there is isolated diastolic hypertension because myxedema will increase the peripheral resistance of the veins, and there will be increase in diastolic blood pressure, but the systolic will remain normal, and there will be low heart rate in hypothyroidism, but there will still be hypertension. We should get a thyroid functioning test done on baseline, or baseline thyroid stimulating hormone test done to rule out secondary cause of hypertension. If hypertension shows a sudden onset in someone aged more than 55 years old, or if there is hypertension present in someone less than 30-year-old, consider secondary cause of hypertension. Pheochromocytoma will cause episodic hypertension. Uh, the neurogenic cause can be a transaction of spinal cord or at C6 or below. And what is Cushing reflex? So decrease in heart rate and increase in BP, it is known as the Cushing reflex. There can also be Mendelian causes of hypertension like Liddle syndrome, in which there is a gain of function of the ENaC channels. So there is hypertension with hypokalemic alkalosis in Liddle syndrome. There is decrease in aldosterone, decrease in renin, and the treatment for this will be amiloride. And there can be also Gordon syndrome. So there is a WNK1 or WNK4 gene mutation, and there is a gain of function of sodium chloride co-transporters, and as we know, NaCl is bad. It causes hypertension. uh, Polycystic kidney disease can be of two types, that is autosomal dominant and autosomal recessive type. Autosomal recessive is seen in children, and autosomal dominant is adult onset. So USG criteria for this will be there should be more than two cysts per kidney seen on the USG. In the adult onset, there will be hepatic cyst, and in the pediatric onset, there will be hepatic fibrosis. There is abdominal pain, and colonic diverticulitis can also be seen. Pheochromocytoma is another Mendelian cause. So, in pheochromocytoma, it can be seen in men 2A or 2 and Sippel syndrome, in men 2B or 3, and in VHL 1, Hippel Landau syndrome, and neurofibromatosis 1. So, and also congenital adrenal hyperplasia, which is autosomal recessive with the last Mendelian cause. So defect is in the 21 hydroxylase inhibition. So if there is 21 hydroxylase inhibition, there will be no development of hypertension, but there will be hypotension seen. So there is a decrease of aldosterone, decrease of cortisol, and increase in DHEAS, dehydroxyepiandrostenedione, which will cause the virilization of the female child. There is there is 11 beta hydroxylase, which is converted to 11 deoxycortisol, which leads to stimulation of ENaC channels, which will cause hypertension because there is more sodium. And there is 7 hydroxylase inhibition, which will lead to increased aldosterone production, and these will lead to hypertension, and these are called the hypertensive variety. But there is also non-hypertensive variety, which will cause hypotension to be seen, in which the 21 hydroxylase is inhibited. So this was the part 2. This is just for private use, but if anyone else is watching, I'm grateful, and please tell me where I'm wrong, because I think I made some mistakes in this, but I think it is good enough for private use. So if anyone mistakenly watched it, thank you for watching.